Could FDA-approved Vyvgart, efgartigimod alpha FCAB for intravenous infusion, or Vyvgart Hytrulo, efgartigimod alpha and hyaluronidase QVFC for subcutaneous injection help your adult patients? Explore clinical trial data and learn how to get patients started at vyvgarthcp.com. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt from Mayo Clinic Neurology. In today's Neurology podcast, I'm joined by Adam de Havenon, Associate Professor with Yale Neurology. You may recall Adam as he's hosted the podcast in the past, but today he's on the other side of the microphone. He's joining me to talk about his April Green Journal article titled Burden of Neurologic Healthcare and Incident Neurologic Diagnoses in the Year After COVID-19 or Influenza Hospitalization. I thought this was a really intriguing study where Adam and his group looked at the rates of subsequent healthcare encounters for 6 of the most common neurological diagnoses in the year after patients were hospitalized for either severe COVID or flu. Adam, thanks so much for coming on the podcast today.
Thank you for having me, Derek. It's a pleasure being here.
What were you and your group seeing in practice or in the literature that really prompted you to do this study?
This study grew out of the Health Services Research Subcommittee at the American Academy of Neurology. And many of the listeners won't know the HSR subcommittee, as we call it, but it is a subcommittee tasked with looking at issues and applying analytic techniques, typically with large data sets, to topics that are of interest to neurologists or to Academy members. And it became clear that there was concern that following reports of neurologic sequelae of COVID infection, that there could be availability issues for neurologists. And we took a somewhat distinct approach in our analysis, focusing really on metrics of healthcare use and utilization, trying to answer questions that would be relevant to neurologic providers and systems of care, namely, will there be a dramatic or significant increase in the need for outpatient visits or inpatient care for neurologic diagnoses? At this point, the majority of the American population has suffered a COVID infection.
Let's move on to the study design. Can you tell us a bit about why you chose the parameters you did, those top 6 diagnoses, and how you decided to really lay everything out?
We primarily used data from a private company called Trinetics in this analysis. Trinetics is a US-based company that has partnered with, I think, close to 70 healthcare organizations, many of which are large organizations with multiple hospitals or other delivery networks. And we actually obtained the electronic medical records of individuals within these healthcare networks. And it is a remarkable amount of data. Trinetics does curate that data to some degree, but just to give a sense of the complexity of this data pull, it was a 250 gigabyte data set with over 1 billion data points. So some of these individuals, we had 30 years of blood pressures, of lab values, of diagnoses, etc. And you might ask why we chose a data set of this nature. And it was primarily because we wanted to conduct as rigorous an analysis as possible, Derek. And I think that we ultimately achieved that. And we did also do a secondary analysis in the nationwide readmissions database, which is federally developed database that essentially captures a large portion of the hospital admissions in the United States. and within the same calendar year, any readmissions. And the intent of that was more or less a sensitivity analysis to make sure that we felt comfortable with what we found in the primary Trinetics cohort.
Yeah, it's certainly an impressive data set. I mean, you were getting in there in the six figures with the number of patients. So we can talk about your findings and lay out for us what the numbers ended up looking like with regard to subsequent neurological healthcare encounters after severe COVID versus severe flu. Was it or was it not in line with your hypothesis?
The study focused only on adults, so all patients were 18 years or older. In both cohorts, flu and COVID, they had a hospital-based encounter. So they were either seen in the emergency department or admitted to the hospital. So this is a moderate to severe infection population. The reason we did that is it's difficult to fully capture individuals who, say, had a molecular diagnosis of COVID in the outpatient setting. We wouldn't be very confident in having follow-up in those individuals, whereas most everyone who is hospitalized or seen in the emergency department will have some type of follow-up if there are complications, et cetera. The flu COVID cohort is exclusively from 2016 through the end of 19. That was selected because we felt very strongly that we did not want to have flu patients who may have also had undiagnosed COVID. So it is a pre-COVID timeframe. And then the COVID cohort is from April 1st, 2020 through November 15th, 2021. That's primarily the first waves of COVID before large portions of the population are vaccinated. We did exclude individuals who had both a prior flu infection and then a subsequent COVID infection. I will note that in other analyses, these individuals were not necessarily excluded. And in fact, in the majority of analyses I've seen, we felt that it represented a somewhat unique phenotype, people who had recurrent respiratory viral infection. So we made the decision to exclude them. Moving on from the cohort selection, the outcomes of the study included any healthcare encounter, so any billing encounter for a neurologic, one of 6 neurologic diagnoses in the year following the flu or COVID infection. We picked the 6 most common neurologic diagnoses, and those include migraine, epilepsy, stroke, neuropathy, movement disorders, and dementia. Broad diagnostic categories. Overall, we anticipate that this accounts for at least 3/4 or more of neurologic billing encounters. We also created a secondary outcome, which we call incident neurologic diagnoses. This is any of those 6 diagnoses in individuals who never had that diagnosis in the past. And you'll remember, Derek, I said this was an exceptionally large data set. We had up to 20 years of pre-infection data on many of these individuals. So we were able to estimate a fairly robust incident diagnosis outcome. We then did a propensity score match where we sought to balance age, sex, race, ethnicity, marital status, somewhat as a proxy for social support, the U.S. Census region, the number of years of data that were available before the infection, and a comorbidity score called the Elixhauser comorbidity score that encompasses things like hypertension, diabetes, malignancy, substance abuse, a number of other factors that we would want to balance. After performing that propensity score matching, we were left with a balanced cohort of roughly 77,000 individuals with flu and the same amount with COVID. We then performed the time to event analysis with 1 year of follow-up.
I appreciate the background there. I think it displays how nicely you really tried to control for confounders and really tried to isolate flu versus COVID and to really try to see in isolation what the differences were. You mentioned in the intro your hypothesis, and you were going off of some previous literature, but I think one of the pearls here is that you found something different. And so I'll give you the floor to lay out what you found.
Our hypothesis was that we would find an increase in neurologic healthcare and potentially an increase in incident neurologic diagnoses in the COVID cohort, primarily based off the preliminary reports, as I mentioned. In our cohort, which on average was aged 51, 58% were female and 42% were white, so a fairly diverse and representative cohort, we found significantly lower risk of neurologic health care in the year following COVID infection, so contrary to our hypothesis. The hazard ratio for receiving care for migraine was 0.65, so 35% less likely to receive care for migraine. For epilepsy was 0.78, for neuropathy 0.57, for dementia 0.93, and for stroke 0.90. So a range of lower odds of receiving healthcare for neurologic diagnoses in those with COVID. We also found that the incident neurologic diagnoses were lower in the COVID cohort. There was a rate of 2.8% of these incident neurologic diagnoses in the COVID cohort versus 4.9% in the flu cohort, which equates to a hazard ratio of 0.62. Again, finding a lower burden of these neurologic diagnoses in the COVID cohort, contrary to our expectations.
You also mentioned your secondary analysis about readmission rates, and I was hoping you could tell our listeners about what you found there too.
We performed the second analysis really following the surprising results of the primary analysis. The intent was to double check, if you will, the findings. And in the nationwide readmissions database, we identified a large cohort with COVID infection in 2020 and matched them in a very similar method to a flu cohort. And what we found was that readmission for the same neurologic diagnoses was seen in 0.6% of the COVID cohort over the same amount of follow-up up to a year, versus 1.9% in influenza matched cohort. This equated to a hazard ratio for neurologic readmission of 0.79 in the COVID cohort. So really replicating in many respects what we found in the primary analysis.
I think for myself and I think for most neurologists, we also would have found those results surprising for sure. So in the article, I think you also rightfully discuss how these results should be taken in context and perhaps not over-applied or over-extrapolated when it comes to symptoms under the umbrella of post-acute sequela of COVID or long COVID, as it's sometimes called. And I was hoping you could touch on that for our listeners as well, because I think that's important.
I think it is critically important that we delve into that a little. And really from the outset, our intent was not to look at past or long COVID. And there were a couple of reasons for that. The primary is that the symptoms and the burden of long COVID is not captured well in administrative data sets. For example, fatigue, brain fog, anosmia, these are all diagnoses that are poorly coded and really probably reflect disparities in what we deem worth coding or reimbursing in our healthcare system. But that's another discussion that was beyond the scope, really, of what we were trying to do here. So I think that it is very important, though, to say that the results that I have described do not conflict with the known neurologic burden of long COVID. Because again, we were looking at the more classic neurologic diagnoses, things like epilepsy or stroke. And again, I also want to clarify that these are during follow-up. They are not during the same hospital encounter. And a lot of analyses have been published, including one that or two now that I think of it, that I've published, showing that there are higher rates of stroke and worse stroke outcomes in individuals hospitalized with severe COVID. This analysis does not look at that. It is essentially looking at after COVID infection, in patients who are hospitalized or had an emergency department encounter, we are not seeing a larger burden of neurologic healthcare, of visits and billing for these common neurologic diagnoses. And I do think that that's important information. It helps us understand the ongoing impact of workflows around neurologic care. And as this article has been published, I think that it has become increasingly clear that clinics are not seeing an overwhelming increase in the need for new visits for stroke, for epilepsy. Of course, as a specialty, we are chronically plagued by long wait times because of a need for more neurologic care. But I don't think that, at least based off this analysis, that COVID itself will have a dramatic impact on that.
Well, thanks, Adam. I think that's good to really emphasize that distinction, and I appreciate you doing that for us. This might be a good time to mention any or some of the possible limitations in the study.
The most important limitation here is that we were studying people during the first and second and third wave of the pandemic. So this is a time period when individuals may have been less likely to seek healthcare. Of note, we do capture telehealth visits in these trinetics because they are and were billed during COVID. So, but nonetheless, there certainly could be bias related to people having fears to seek healthcare or concerns. And we did see in stroke, for example, we did see a decrease, particularly in the first couple months after the pandemic started, in the February through April, May period of 2020 in stroke presentations. And that type of confounding could also be present in this analysis.
So, Adam, this has been a great discussion. I think in wrapping up, with the practicing neurologist in mind, the answer to this might simply just be no, but do you think that the results from your study could be used in counseling patients who wonder about their neurologic diagnosis and its relationship to a past COVID infection? I've certainly seen a number of patients myself who I'm diagnosing them with X, Y, or Z diagnosis, and they had a COVID infection 3-4 months ago. And I get lots of questions about, that implication. And I just wonder if you think that this study at all allows us to speak on that with any evidence.
The limitations of this type of analysis, of course, this data set was not designed to answer this question. And there is other unmeasured confounding. So I would hesitate to say that anything definitive can be derived from this study. But there's an abundance of evidence that neurologic conditions can happen during acute infection. So stroke, for example, or demyelinating polyneuropathy. If those happen immediately after or during acute infection, I think it's very plausible to say those are related to COVID, as they would be related to a severe influenza infection if they happened in that temporal framework. In terms of what we can tell patients who, say, have a stroke 6 months after they had a COVID infection, I do feel that this data and other data that has come out that we haven't discussed, but is supportive of these findings, suggests that people who recover from a COVID infection are not necessarily at long-term increased risk of these major neurologic diagnoses, in so much as their recovery is complete. I think we have evidence at this point that COVID behaves similar to other respiratory viruses in terms of long-term risk of neurologic disease. That isn't to say that there isn't a burden of long-term neurologic sequelae of viral infections. Of course, there is. But I think this data argues against COVID being a really unique player in that space.
I agree. I think it really does speak to the fact that it's a virus just the same as, it's its own entity, but it was certainly not more likely to have one of those coincident para-infectious or post-infectious sequelae than a lot of other common viruses. So I think that's helpful. And I think what you mentioned about the time frame, the temporal profile, once you're outside of that acute, subacute window, outside of that post-infectious, peri-infectious window, just like any other viral illness, we probably should not try to make more of it than it is, although because of most of our population being infected and the media attention, it's just a common question we get. So I appreciate you trying to lay it out for us. I think that's helpful. So Adam, I appreciate you joining us today on the podcast. Go check out the full article in the Green Journal, and we really appreciate you coming on.
Thank you, Derek. Always a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.